All right, moving on to our next speaker. We have Shoshana Streiter here with us. Dr. Streiter leads the HOPE pathway, which is a co-management service between geriatrics and internal medicine, which she initiated in 2019. And she's also an instructor in medicine at Harvard Medical School. And so today, Shosh will be talking to us about delirium management in older adults. Welcome.
Liz, thank you for the kind introduction. Today, I want to talk about the adverse consequences of delirium. I want to describe a practical framework for preventing delirium and develop together some non-pharmacologic and pharmacologic strategies to manage it if and when prevention doesn't work. I have no disclosures. We're going to begin with a basic introduction about delirium. Then we're going to move on to an evidence-based approach for the prevention and management of delirium. First, we're going to focus on non-pharmacologic strategies. Then we're going to talk about pharmacologic strategies. I give you my solemn word of honor. I will keep it down to earth and practical. So what is delirium? Although the pathophysiology isn't well understood, from my perspective as a bedside clinician, I think of it as an imbalance between a person's cognitive reserve and the cognitive stressors that person is exposed to. Essentially, it's a stress test for the brain. And just like a heart with atherosclerotic arteries is going to struggle to perfuse itself when it needs to beat faster and pump more blood to the body, a brain with limited cognitive reserve is going to be vulnerable to poor function under stressful conditions. And a hospital stay can be incredibly stressful, which is why I'm sure every single person on this talk who works in hospital medicine has seen delirium before. Let's consider the case of a 93-year-old man with a history of dementia complicated by behavioral disturbances who's admitted to the hospital with a pneumonia. On cognitive exam, he's visibly agitated. He's getting out of the bed. It's hard to redirect him. He does know his name. He tells you he's at home. He doesn't know the day of the week. He tells you it's 1967, and he can do 3 out of 7 days of the week backwards. Is he delirious? So I think my color bars have basically stopped moving. I agree with everyone who chose option C. I don't know if he's delirious. And if I'm going to use a validated tool to determine whether or not he does or does not have delirium, one of the most user-friendly bedside tools I know of is the CAM, the Confusion Assessment Method, although there are many others. And the version of the CAM that I'm going to briefly run through right now is technically the 3D CAM. It's a shortened, simplified version of a longer tool that was initially developed for use in the research setting, then simplified for use at the bedside. It's a 4-item tool for assessing whether or not a patient has delirium. And in order to be CAM positive, a patient must meet the first criteria, which is an acute and fluctuating change in mental status, and must meet the second criteria, which is inattention. And that's why I do tests like, can you tell me the days of the week in backwards order? That's a formal test of deliria of attention. Additionally, to be CAM positive, a patient needs to meet either criteria 3 or criteria 4, disorganized thinking, which is assessed by orientation questions, and altered level of consciousness. So is your patient hypoactive or hyperactive? The reason the 93-year-old gentleman we just considered may or may not be delirious, I don't have enough information to determine that yet, is because in order to meet criteria 1, you need to know what the patient's cognitive baseline is. And if you don't know their baseline, either from knowing the patient previously or more likely in the hospital medicine setting from getting ancillary history, you really can't determine formally if they're delirious or not. And we worry about delirium because it's incredibly common, seen in somewhere between 30 to 60% of patients on a general medicine floor, depending on which study you're looking at and which screening tool the study is using, and significantly more common, unsurprisingly, in the ICU setting. And the outcomes for patients with delirium during an inpatient hospitalization are really, really dismal. So patients who become delirious during a hospitalization are at significantly increased risk of a subsequent diagnosis of dementia. They're also at increased risk for future institutionalization and mortality, and many other adverse outcomes, including hospital morbidity, length of stay, and cost of stay, go up dramatically for patients with delirium. And not only is delirium a warning sign for patients that are vulnerable to adverse outcomes during a hospitalization, it's not something that ends quickly either. So when I was a resident, I wish I had had a clearer understanding of how persistent delirium can be following hospital discharge. I used to tell patients and their families this is a condition that your loved one is experiencing because they're in the hospital and this is a very stressful environment, and most particularly for their brain. But when your loved one leaves the hospital, goes back home, this confusion is going to melt away like snow in July. And that is true for many people, but not for many others. Consider this meta-analysis from a long time ago, 2009, but very well done, looking at studies that evaluated the persistence of delirium after hospital discharge. In this meta-analysis, the authors found out that a little over 40% of patients were still delirious at the time of discharge if they had been delirious during the hospitalization. This isn't at all surprising. It's pretty intuitive. However, over 30% of patients were still delirious 1 month after discharge. About 24% were still delirious 3 months after discharge, and terrifyingly, 21% were still screening positive for delirium half a year after leaving the hospital. So, one thing we can really do to support our patients and their families is give them a realistic idea of what to expect after they leave the hospital. My take home from this is that it is true that delirium usually gets better once a patient leaves the hospital, but not always, and definitely not quickly for many people. Factors that put individuals at risk for developing delirium during an inpatient stay are pretty intuitive. Older age is one of the most pronounced risk factors, as is pre-existing cognitive impairment or dementia. Functional and sensory impairments will also increase the risk. Male gender, and how sick the person is. The more comorbidities they have, the more likely they're going to be to develop delirium during an inpatient hospitalization. Environmental factors that increase the risk are also pretty intuitive. Restraints and or immobilization, increased length of stay, being in the ICU, not sleeping, experiencing a fall during a hospitalization, and experiencing a change in location are all factors that will put a person at risk for delirium during an inpatient stay. So to summarize what we've discussed thus far, delirium is really common, it's really bad, it's persistent over time, and we typically have a pretty good idea of which patients are likely to develop it. So how do we help these patients? First, I'm going to discuss non-pharmacologic strategies, which are absolutely the first-line approach to prevention and management of delirium. And I'm going to assume that most people here have at some point been responsible for the care of a very small child, either your own or a family member's child or a loved one's child, or during a pediatrics rotation in your medical training. Imagine that it's 2 a.m. and there is a baby that is crying and will not stop crying. What is the first thing you're going to do? Well, you are most definitely not going to first reach straight for Haldol. You're probably going to pick the baby up, you're going to give the baby a hug, and you're going to try to figure out what's upsetting the baby. And this is exactly the right approach to be taking in our hospitalized older adults. Is something hurting them? Are they hungry or thirsty? Are they wet or soiled, et cetera, et cetera? What is the source of the distress and how can we alleviate it? To quote my friend and fellow geriatrician, Dr. Sandra Shee, giving antipsychotics for delirium without first considering the need for pain control is like giving paralytics without sedation. Don't do it. And while we're considering why this person is crying out and acting out and agitated and distressed, since we actually are talking about hospitalized older adults, and this is not actually a pediatrics lecture, we have to consider, is there an unidentified or incompletely treated disease process going on, like an infection, probably the simplest example? And is this medication induced? And one of the mantras in geriatrics is a new problem in an older adult is medication induced until proven otherwise. And during inpatient hospitalizations, it's really common for patients to be exposed to new medications that put them at risk for cognitive compromise or for alterations in their renal and hepatic function to put them at risk for cognitive side effects of medications that they'd previously been on but tolerated well prior to the hospitalization. I said earlier that non pharmacologic management is absolutely first line for delirium. And this assertion is based on a seminal study from the late 1990s, where researchers identified 6 prominent risk factors for delirium: immobility, impaired vision and/or hearing, dehydration, cognitive impairment, and impaired sleep. This is pretty intuitive. But what was less intuitive at the time this study was being done in the late 1990s is that the team developing this study decided that every single one of these risk factors is totally modifiable in the inpatient setting. And the team that conducted this study developed a structured, volunteer driven approach to systematically improving each of these elements of the patient's daily experience during an inpatient stay. They called this program the HELP program, which stands for Hospital Elder Life Program. And before showing their findings, I'm going to throw out a few super simple, super common sense, easily applied strategies towards addressing each of these risk factors. And we're going to start with talking about sleep. So this is a verbatim page about a patient who was cared for in my hospital a couple of years ago, admitted with a UTI, but getting better on antibiotics. And this is exactly the page I got, except the original page said, patient delirious, poor sleep, no help from melatonin or trazodone, query Seroquel instead of quetiapine, because I'm not supposed to use brand names for this talk. And my first question wasn't what pharmacologic agent is most likely to help this patient sleep, but why isn't this patient sleeping? And because our EMR timestamps absolutely everything under the sun, as do many EMRs, the first thing I did was review the timestamps in the EMR to get a sense of what the person's nocturnal experience was like. And what I learned was that this poor patient had not had more than 2 hours of uninterrupted sleep for a solid night. So when I walked into the room at 10 a.m. to introduce myself and assess the patient, she was sound asleep, not surprisingly. And my take home is that there is not enough Seroquel in the world to solve this problem. But that's okay, because you don't actually need Seroquel to solve this problem. You just need a few super simple common sense strategies towards promoting sleep in the hospital. For example, knowing to look for timestamps of things like medication administration, blood draws, vital checks, turning and repositioning, finger sticks will give you a sense of potentially solvable, modifiable problems that are keeping the patient up overnight. Look at when medications are timed and consider whether you can consolidate them so they're not being administered overnight. Ask your patient, what is your normal sleep routine at home, and try to mimic that as closely as possible in the inpatient setting. If I am resorting to medications to help optimize sleep in the hospital, I'm probably going to use melatonin as my first choice and trazodone as my second choice, because the side effect profile of both of these agents is pretty favorable. If this fails, I would likely try suvorexant, which is an inhibitor of a neurotransmitter called orexin, next, although this would be kind of my third line, would prefer not to use that agent because it is quite expensive and I don't want to discharge a patient on it without a good plan for continuing it in the outpatient setting. Moving on from sleep to mobility, what are some super simple things we can do to improve patients' mobility while they're in the hospital? Well, be thoughtful about what we're doing to keep the patient in place. Think about tethers. Do they need telemetry? Do they need a catheter, whether it's external or internal? Do they need IV lines? And if they're getting IV fluids, do they need to be continuous maintenance fluids, or would boluses during the daytime hours suffice? That's much more comfortable for most patients. If they're getting tube feeds, do the tube feeds need to be around the clock, or can they be cycled? If a patient is immobilized because they have behavioral disturbances and they're being restrained, would it be possible to put them on one-to-one observation and take away the restraints? And can they be moved into a setting that's more conducive to mobility, such as a recliner in the hall or a recliner next to the nursing station? Improving sensory input, trying to tackle the risk factors of both visual impairment and hearing impairment. Make sure patients who need them have access to hearing aids and eyeglasses. Pocket talkers or pocket amplifiers can be incredibly helpful with patients who are hard of hearing. Many hospitals will have them available, and if your hospital doesn't, they're usually pretty easy to get. They're available for about $20 on Amazon, although you could get a super fancy expensive one for quite a bit more than that if you want to. Voice to text apps such as iHear, which is available for free in the Apple and Android stores, is also incredibly helpful for patients that have the cognition to read text but have difficulty hearing. And for patients who do not speak English as a native language, inpatient translators are often infinitely preferable to video or iPad translators if you're lucky enough to have them available in your hospital, which I will freely admit is not always the case. To help promote healthy cognition in the hospital, really focus on reorienting your patient as needed, on making them aware of who the people around them are and what their role in the care team is, orienting them to place and time using devices such as a whiteboard or the calendar, leading into family and friends being part of your care team, encouraging them to be at the bedside, to bring in familiar objects from home, things that will help the patient reorient. And absolutely do not discount the power of your volunteer department. Most specifically, the therapy dogs can be incredibly helpful in staving off delirium. Improving hydration is something that's been well shown to reduce the risk of delirium in older adults. And this is something I want to spend a little extra time thinking about. It's really critical to make water accessible to patients, encourage frequent drinking, and reduce keeping patients NPO unless it's really absolutely necessary. So we've probably all been in the position of scheduling a procedure for a patient that they need to be NPO for. Then the procedure gets delayed and your patient ends up being NPO for days and days on end, waiting for a procedure to be scheduled and rescheduled. Double checking scheduling can be incredibly helpful in protecting hydration status and kidneys in our older adults. And one point that I really want to spend a little bit of time thinking about is reassessing the risks and benefits of thickening liquids, which is a strategy we often implement in older adults in the hospital with dysphagia to reduce the possible risk of aspiration events. Now, our understanding of the risks and benefits of thickened liquids is evolving as the evidence base for their use evolves. And very briefly, I'm going to reference a retrospective cohort study that was published in JAMA Internal Medicine earlier this fall, looking at whether thickened versus thin liquids reduce the risk of in-hospital mortality in hospitalized older adults. And in this study in particular, they looked at a cohort of older adults with what they called either Alzheimer's dementia or Alzheimer's-related dementia. You often cannot confirm that the dementia is actually Alzheimer's. You often don't have biomarkers. And if you look at this Kaplan-Meier curve, the thin liquid line and the thick liquid line look exactly the same. You can probably not see much of a difference on your screen because there wasn't a significant difference in terms of in-hospital mortality, regardless of whether the liquids were thick or thin. And this study made it all the way to the New York Times. So it's possible you may start hearing from patients and their families questions about whether or not the nasty sludge that's being put in their coffee is actually helping their health. And because thickening liquids has been shown to increase the risk of dehydration and reduce quality of life for patients on thickened liquid diets, it really is something worth considering, especially in the context of delirium risk when we know that dehydration increases the risk that patients will become delirious. So, going back to the Hospital Elder Life Program, the study that systematically addressed these 6 risk factors for older adults in the inpatient setting developing delirium through a structured volunteer-driven program. In this study, the incidence of inpatient delirium was reduced from 15% in usual care to 9.9% for patients being cared for by the HELP program, the Hospital Elder Life Program. And this is really quite astonishing. This is essentially a zero cost, basically zero risk intervention that cuts the likelihood of this very dangerous syndrome for older adults by a third with no risk and no cost. Absolutely, the first line for helping patients at risk for delirium is non-pharmacologic management. But reducing delirium incidence by 33% is not the same as reducing it by 100%. And we all know that even when we do our absolute best to optimize non-pharmacologic prevention strategies, some patients will still become delirious. And when they're delirious, we can't always keep them safe non-pharmacologically, although we would like to. In our remaining time, I'd like to review some basic principles of pharmacologic management of delirium so you have practical tools to help the patients for whom non-pharmacologic strategies just aren't working. Consider a 73-year-old I cared for in the early winter days of 2020 when a lot was happening, generally healthy, but admitted with shortness of breath and found to be COVID positive. This person was hypoxic in the emergency department, rapidly intubated and admitted to the ICU, extubated after 8 days, transferred to the floor the next day, very agitated, thrashing in bed. He was getting tube feeds via his third dob off. He pulled the first two out, and the staff just doesn't feel safe caring for him with the degree of agitation he's exhibiting. None of your non-pharmacologic interventions are working. And I'm going to ask you to assume that everything possible was tried, which I will tell you what's the case. We're going to turn to pharmacology. What agent would you try first? And we should be having a word cloud pop up here, so people should be able to text or type in the agent they would turn to. Yeah. I love whoever wrote I do not know. I totally feel that way all the time. Yeah. So I'm seeing a ton of variability here. Looks like a lot of people were turned to Haldol, which is not unreasonable. Fair number of people were turned to Seroquel, and there's some olanzapine in there. Pretty much everything else is too small for me to see. But my take home from this adventure in word cloud on Zoom is I don't know, is a really good answer. There's a ton of variability in the agents that the people in this talk would reach for, and that's reasonable. Every few years, another meta analysis gets published looking at studies that compare either different sedating agents to each other for patients with delirium or different sedating agents to placebo. And every time another one of these meta analyses come out, they're inconclusive. Over and over again, we learn that we really don't have good evidence, although we've tried and we've looked for the evidence to tell us this particular agent is the most efficacious or the most safe or both for managing symptoms of hyperactive delirium. So, in the absence of good evidence telling us what the most efficacious approach is pharmacologically, I would advocate for a pharmacology driven approach. What do I mean by that? If you have a good understanding of the basic pharmacology of the commonly used agents for hyperactive delirium, you can usually do a pretty decent job of tailoring a med management plan to your individual patient. And the particular parameters that I find especially helpful to know and think about include route of administration, half-life, and side effect profile. So I'm going to run through a couple of the commonly used agents that we often reach for on the hospital floors to help keep patients with hyperactive delirium safe. Starting with Haldol, which was biggest on the word cloud for good reason. It's probably the oldest sedating agent we have on formulary. It's pretty well understood, pretty well studied. This has a half-life of the super variable. If you look in Micromedics up-to-date or pharmacology textbooks, you'll see a range of about 12 to 38 hours, which is really huge because there's a lot of variability in hepatic metabolism. But in my experience, the half-life is often about 12 to 14 hours. Big advantage of Haldol is that it can be administered in pretty much every route you want. We have it available POIM, IV. There's even a sublingual formulation. This is a really useful piece when you're thinking about how to help patients that may be too agitated to swallow a pill. It can be pretty effective at maintaining safety in patients with behavioral disturbances, even when given at incredibly low doses. I typically start at a starting dose of 0.25 to zero point 0.5 milligrams. It's very well known that Haldol confers a high risk of extrapyramidal side effects and a high risk of arrhythmias, especially in patients with prolonged QTC. Moving on to another relatively commonly used agent, risperidone. Half-life is about 20 hours. Similarly, broad route of administration. Risperidone also comes in an ODT formulation, an oral disintegrating tablet, which can be very helpful in patients that have difficulty swallowing or are too agitated to swallow. Similarly to Haldol, it confers a high risk of both extrapyramidal side effects and arrhythmias, but slightly less than Haldol, and it's also a little bit less sedating. Olanzapine is a second-generation antipsychotic, and I want to draw your attention to the half-life, a whopping approximately 21 to 54 hours. This is a real disadvantage of olanzapine because if you give it and your patient is particularly sensitive to it and becomes oversedated, you're going to be dealing with the effects of that oversedation for about 3 days. And if you're talking about a frail older adult who is not mobilizing or working with PT or eating well or drinking for 3 days, that can cause an awful lot of problems for your hospital stay. So treat the half-life of olanzapine with a lot of respect. Advantages of olanzapine include multiple routes of administration, PO, IM. It's not FDA approved IV, but it can safely be used IV, and also oral disintegrating tablets, similarly to risperidone. It has a lower risk of precipitating both extrapyramidal symptoms and arrhythmias than your first generation antipsychotics. And a particular advantage of olanzapine is it has a pronounced antiemetic effect, which can be really helpful in patients, for example, who are delirious and recovering from intra-abdominal surgeries and maybe suffering from severe nausea. Quetiapine is often an agent I will reach to first if I'm thinking about the class of antipsychotics at all, because it is the most sedating of the antipsychotics, which is often what I want if I'm thinking about keeping a patient with behavioral disturbances safe. And it has the shortest half-life, only 6 hours. So that means I'm less worried about oversedating my patient for a prolonged period of time and then dealing with a patient who is not eating or drinking or moving and all the consequences therein. A big disadvantage of quetiapine is that it's only available PO. So in order to use it, your patient needs to be able to swallow a pill or willing to swallow a pill. Another important point about quetiapine is of the antipsychotics, it's the least likely to precipitate extrapyramidal side effects, which means it's the agent of choice if you must use an antipsychotic in patients with Parkinsonian syndromes. To briefly touch on aripiprazole, like olanzapine, I'm going to draw your attention to the whopping half-life of 75 hours. This is not a drug that is in and out in a hurry. In my experience, less frequently used for hyperactive delirium, which I think is appropriate because that half-life is a real concern. Another downside of aripiprazole is, like quetiapine, it's only available in PO formulation, so you can't use it if the patient cannot effectively swallow a pill. The useful clinical pearl to know about aripiprazole is that of the antipsychotics, it's considered arrhythmia neutral. It confers the least risk of QTC prolongation, although you will find case reports of patients who take aripiprazole and then develop either a ventricular arrhythmia or, I think, a little bit more likely the ventricular arrhythmia and atrial arrhythmia. So it's considered safe in patients with prolonged QTCs at baseline. To briefly touch on several non-antipsychotic agents that came up on the Wordle and come up in real life and are often used for delirium. Trazodone, which is a 5-HT2 receptor antagonist and inhibits serotonin reuptake, has a mild sedative and anxiolytic effect, especially at low doses, and it can be effective in patients with mild delirium. Depakote, which is an anti-epileptic, can be given PO and IV. It's not been well studied for use in patients with delirium, but it is generally well tolerated. Its sedative effect can be very helpful. If you use it, you need to monitor for hepatotoxicity. There's no evidence that clonidine works for patients with delirium, although I have often seen it tried. And there's no evidence that cholinesterase inhibitors, which are often used not in patients with delirium, but in patients with dementia, work for delirium. And there's really good evidence that benzodiazepines make delirium worse. So let's put this all together. Your patient has delirium. My first question is the patient safe or unsafe? If the patient is safe, I'm not going to reach for pharmacology. I'm going to tolerate mild agitation. I'm going to tolerate yelling. I'm going to even tolerate wandering as long as the patient is safe. If the patient is unsafe, I want to know if the patient can or can't take PO. If the patient can take PO, I want to know if the QTC is normal or prolonged. If it's normal, these are the agents in your toolbox. I'm probably going to start with trazodone because of the favorable side effect profile and escalate from there based on the pharmacologic profiles of the different agents. If the QTC is prolonged, Abilify is probably your best option because it will not predispose your patient to arrhythmia or prolong the QTC even more. Olanzapine and quetiapine are less likely to prolong the QTC, and it is reasonable to consider cautious use, even in patients with prolonged QTC, although very cautious. And Depakote will also not prolong your QTC. If the patient cannot take PO and the QTC is long, olanzapine and Depakote are two reasonable agents to consider. And if the QTC is normal, Haldol, olanzapine, and risperidone are all reasonable options. Now, make it a little more complicated. If your patient has delirium and an underlying Parkinsonian syndrome, and your patient is safe, avoid pharmacology. If your patient is unsafe, same question. Can the patient take PO or not take PO? If the patient can take PO and the QTC is normal, options in your toolbox include trazodone, quetiapine, or Depakote. If the QTC is long, you really want to stay away from trazodone and use quetiapine cautiously at low doses. Depakote is another good option that won't precipitate extrapyramidal symptoms or worsen your QTC. If your patient cannot take PO agents, you really have very, very few options that you can safely administer. I would try Depakote as first line in this situation. Remember, it does come as an IV infusion. And if it doesn't work, and if I absolutely cannot keep the patient or my team safe, that's when I would reach for lorazepam. In summary, we've considered a basic introduction to delirium. We've talked through some non-pharmacologic and pharmacologic strategies for both preventing and manage delirium. Thank you so much for your attention, and I would love to take any questions people have.
Thank you so much, Shosh. That talk was incredibly helpful, both in terms of preventing delirium and then also just how to manage it with the decision tree at the end. I think we all really benefited from that. So the first question is, I know, near and dear to your heart, and it's about mobilization and fall risk. And so when we think about mobilization and delirium prevention, what kind of educational interventions for staff have been effective in the literature? And the participant notes this can be challenging with staffing shortages and with unit metrics emphasizing no fall days.
I love this question. It's so clinically relevant and so important. I would start by saying, what are the interventions that we frequently do that have been shown to not be effective? And I'm going to put this to the group. Can people put in the chat what interventions don't work for mobilization and delirium? We don't have chat. Oh, I can't interact. I'm sorry, everyone. So one thing I was hoping would come up, because it always comes up, is bed alarms. Bed alarms have not been shown to keep patients safe from a falls perspective. They have been shown to increase agitation, and they worsen mobility because we keep patients in bed and we don't mobilize them. So probably the least safe thing you could do, very counterintuitively, for a patient who's high falls risk is put them in a bed and not let them out of bed. And I recognize that ambulating patients who are agitated, who may have baseline dementia, who on top of it have delirium or are at high risk for delirium, can be scary. And I absolutely recognize that there will be a risk of falls with many of these patients. But I would say that keeping these patients in bed with strategies like putting them on bed rest, putting them on whatever your particular false precautions may look like, if they include immobilizing the patient or putting them on a bed alarm, is not going to help. What has been shown to help is frequent and assiduous nursing safety checks. So put the patient in a place where you can keep eyes on them, frequently redirect them, mobilize them as much as possible, recruit family to help them do bed mobility exercises to keep their muscles working. And this is going to be challenging, and it takes a lot of trust with your staff, particularly your nursing staff, and a lot of teamwork, and it's probably not going to look perfect.
Great. In terms of insomnia management, participant notes that there's been literature cautioning against higher doses of melatonin due to disruptions in the HPA axis. And do you agree that sticking with lower doses in the range of 1 to 3 milligrams is optimal?
Yeah, that's a great question. Absolutely. So there is a theoretical concern with melatonin that if you give high doses of exogenous melatonin, you're going to suppress the brain's production of endogenous melatonin and counterintuitively dysregulate the sleep-wake cycle. Now, one of the difficult things when you're talking about dosing melatonin is that it's regulated as a supplement. It's not regulated as a drug. So there's variability in the active agent of whatever formulation you have in the Pyxis at your particular hospital. And it's really hard to compare different doses because of this difference in regulation. That being said, because of the theoretical concern of suppressing endogenous melatonin production, I will always, always, always start at the lowest possible dose and see if it's effective. So I typically start at a dose somewhere between 1 to 3 milligrams. And I don't know if I've ever gone over 6 milligrams, and I rarely go up that high. If you go up that high, it's probably not the right agent and not working.
Great. Another question about data around restraints in delirium, or if not great data, like what's your approach?
Did the person who asked the question specify mechanical or chemical restraint?
I think it's mechanical for this question.
Mechanical restraint. So not a lot of data. You can imagine that all the trials looking at restraints with delirium are retrospective, because how are you going to do any other ethical trial looking at restraints in patients with delirium? And it remains an open question whether chemical or mechanical restraints result in better outcomes for patients. I would love someone to design and carry out that trial because I really want the answer. But mechanical restraints in delirium are absolutely a last resort. They will increase your patient's risk of agitation. They will increase your patient's risk of post-hospitalization PTSD. And they also severely limit mobilization, which we know is a risk factor for worsening delirium. So I would say if you are more worried that your patient or your staff is in imminent danger of clear harm without mechanical restraints, use them as a last resort if someone is about to get hurt. Obviously, we need to keep our patients safe, but I can't think of any time in the last year that I've had to resort to them, because it's still very much something that will worsen delirium.
Yeah, that makes sense. And then sort of a common vexing question for many of us is sort of you have a patient who comes in with altered mental status and pyuria, and you can't elicit symptoms. And so what's your recommendation for approaching these cases of attributing the altered mental status to a UTI?
I love this question. Love this question. So determining a UTI in an older adult, and most particularly in an older woman, can be quite challenging because, as is pretty well known, about 75% of older women have their urinary tract colonized with bacteria. And it's really hard to tell what the difference is between asymptomatic bacteriuria and a true UTI. Now, delirium and or altered mental status, which can be delirium or can be not delirium, can absolutely be a symptom of an older adult. And in fact, one of the common teaching points with delirium is that I think about it as a vital sign, kind of like a new temperature in an older adult. And if I see new changes in mental status in an older adult, I'm always going to ask myself, is there some underlying untreated pathology, such as an infection, such as a UTI? That being said, your UA is not going to be particularly helpful in distinguishing between asymptomatic bacteriuria and UTI. And there are many, 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 many other common causes of delirium apart from a UTI. So before I would jump to saying the patient is altered, my UA is uninterpretable because this patient is probably colonized, let's empirically start antibiotics. I'm going to first assess for other causes, and I'm not going to run through all the potential other causes because they're so well known. But is the patient constipated? Is the patient retaining urine? Is the patient in pain? Is the patient scared? Has the patient been started on a new medication, et cetera, et cetera? I will probably not treat for infection if all I have is altered mental status and a quote unquote positive UA because I don't know what that UA means. I don't know if it's asymptomatic bacteriuria unless there are other focal signs or symptoms of infection. So is the patient febrile? Has the temperature elevated beyond the basal body temperature? Because there are different criteria for fever per the IDSA in the older adult population. Is the white count up? Am I observing the patient during urination and seeing grimacing or signs of distress? That could actually be a clincher for, oh, actually, there are urinary symptoms. The patient can't express them, but I can see them with my own eyes. But in general, and most particularly in the inpatient setting where it's not hard to closely monitor for signs or symptoms of infection and have a very low threshold to start antibiotics quickly, if we do see signs or symptoms that are more likely to be an infection than the incredibly non-specific manifestation of delirium, I'd usually be inclined to say, let's monitor this patient closely. If things change clinically, low threshold to start antibiotics, but because we all know that unnecessary antibiotics can cause a whole lot of harm, both on an individual and a population basis, I really try very hard to avoid treating agitation with empiric antibiotics.
Perfect. And last question, if you had a magic wand and you could stop one harmful or maybe unhelpful practice that many of us do, what would that, for older patients, what would that be?
I love this question so much. Make the overnight vitals disappear. Everyone needs sleep. Older adults need sleep. Cognitively impaired older adults desperately need their sleep. There is no earthly reason for the vast majority of older adults who are not hospitalized in the ICU and who are hemodynamically stable to get woken up at midnight and 4 a.m. for vitals checks. Stamp them out from the face of the world. I want that magic wand, and I want it today.
Perfect. Well, you heard it from Dr. Streiter herself. So thank you so much for joining us and sharing your knowledge. It was a great talk.